Yeah. So welcome you all for this 26th edition of Peculiar Case Series Renal Transplant. It has been moving continuously for the past 2 years without any break, except for one break because of ISM. And it has been a great knowledge sharing platform. And we have a group, WhatsApp group, where we used to have a good discussions and high-tech discussions going on. Nice to see that we are bringing everybody in that one forum of a transplant. And this session is no way different from others. We have two talks followed by discussions, and chairing these two shots that we have two panelists. I'm very much happy and privileged to invite Dr. Shivakumar sir. He's a professor of Sri Venkateshwara Institute of Medical Science, Tirupati, and after superannuation as a head and professor from that institute. He was a former dean of SWIMS University, and he was a past president of ISPD and ISN Southern Chapter. And everybody in this forum know about him, in India know about him. And he was awarded a Dronacharya Award by Avatar, and he also received a Best Teacher Award from Andhra government also. And I have a privilege of attending him as a postgraduate trainee, as a special posting in 2013. And what we look into him is the insightfulness, actually. He will go an extra yard into the subject and will ask questions which many of us will know that don't know the answers. And Stan is a voracious reader and is a very good academician. And the thing is, the basic thought and the depth and the knowledge, which separates him from others. And joining him is Dr. Swarnalatha. And again, this platform doesn't need much introduction about her. And she has been helpful and helping us in making this program to run. And she's an additional professor of nephrology at Nizam's Institute. And she has more than 60, 70 publications. And one important thing is she's doing research in immune tolerance renal transplant, which we will be discussing later, madam, in some other time. And she is a reviewer for many international journals like She International, IJMR, and IJN, and Saudi Arabia Journal of Kidney Diseases. And she is heading the disease donor transplant program in Telangana. And Madam, as we all know that, she is insightful one, and she has a very depth in knowledge and knowledge in nephrology, and her nephrology education group, and similar to this Peculiar Series group, has stimulated many PGs to read the journals through the mails. It has been in work for the past 15 years, I think so. And we have two presentations, and fortunately
a small correction. I'm the professor and the head of the department with very...
Yeah, sorry, madam. Actually, the CV which was sent by read as additional professor, she is a professor of nephrology at Nizam's Institute. And sorry for this beg your pardon. And joining, we have two talks and will be delivered by the two young and budding and nephrologists. One is by Dr. Venkatesh. He's a consultant nephrologist at Apollo Hospital, Chennai. And I'm proud to be his contemporary in Deyam. And she has a very good interventional work in Chennai. She was trained in intervention nephrology under ISN fellowship program in US and South Korea. And he's doing a good number of transplants. And this presentation of his transplant will evoke many questions of the complications also. And the second speaker is Dr. Balaji. He's from Kaveri Hospital, Chennai, consultant nephrologist, and he's a firebrand nephrologist. He's an active in academics, and he had very much poster and podium presentation in various conferences. And he has another talent of having a very good Indian classical music talent, and he used to deliver this during his time. So without wasting much of the time, let me invite Dr. Venkatesh to start his presentation. I think his resident is going to present the case.
Yes, Dr. Rajan, thanks for the introduction. Thanks to Dr. Swarnalatha ma'am and Dr. Shivakumar sir for chairing this session. I'll ask my postgraduate registrar, final year registrar, Dr. Vivek Kaushik, to present the case, Dr. Rajan. Dr. Vivek, please start.
Please share your screen, please.
Yes, sir. Are the slides visible, sir?
Yeah.
Yes.
Yeah.
Fine.
Good evening to everyone. I am Dr. Vivek. Thank Dr. Venkatesh sir for allowing me to present this case today. This is a case of early graft loss. We titled it as a common foe in an uncommon location, and we would like to present the case. So this is a patient who is 28 years of age, a female from Andhra Pradesh. She was married in 2020, and in 2021, when she visited a gynecologist for infertility, she was found to have a high creatinine of 4.9 with a hemoglobin of 7.7, with a urine protein of 2+ and no sediments at that time, with the shrunken kidneys. She lost follow-up after that, and until August 2022, where she came back with a creatinine of 8.3 with a preserved urine output of about 1.5 liters per day. We went back to the history for looking at the cause of primary disease, as biopsy was not possible. There was no history to suggest a connective tissue disease, a hereditary nephritis, or drug-related or vasculitis, or any history of recurrent UTI, recurrent hospitalizations, or past urological surgeries, which would lead us to a probable diagnosis of a chronic pyelonephritis. So this progressed to a creatinine of 10.8 in January 2023, where the ultrasound showed confirmed bilateral small kidneys, and with anemia and with the high, bone mineral disease, with the connective tissue workup being negative here. Obviously, the next line of management is going to be dialysis and then transplantation. So a bladder assessment was done where the MCUG showed grade 3 VUR on the right and grade 1 on the left. Urine culture done at this time was sterile. So transplant workup was done. Her blood group was B positive. CDC and flow cross match were negative. Retroviral HBV HCV workup was negative. Mother was willing to donate, and HLA showed a haplomatch. The donor details: 52-year-old, B positive. So B positive to B positive transplant. No comorbidities. Hemoglobin was 12.5. Creatinine was 0.8. 24-hour urine protein was okay. Her urine culture was sterile too, and DTPA renogram showed right kidney with 55% and left kidney 45%, with 2 renal arteries and a single renal vein on the left side, and left side was selected. So just prior to the transplant, a right internal jugular catheter was placed. 4 sessions of dialysis were done, followed by transplant on the 1st of March. The total ischemia time was 68 minutes. The main renal artery was anastomosed with right internal iliac artery. Accessory renal artery was anastomosed with right external iliac artery, and the renal vein was anastomosed with right external iliac vein. She was induced with ATG of 50 milligram and methylprednisolone of 1 gram. Had a good urine output. The creatinine was 3.5 on POD1. There were some events during the hospital stay. The most important one was on POD2. She developed sudden uprolling of eyes with tongue bite and some which lasted approximately 3 to 4 minutes. There were no obvious clonic moments. An MRI brain, and there was a post-ictal confusion after that for about 3 to 4 hours. An MRI brain then showed a possible posterior reversible encephalopathy. She was given lorazepam and then started on levetiracetam. This was showed some hyperintensities in the cortex, probable posterior reversible encephalopathy, presumed to be probably due to CNI, and so CNI dose was reduced. By this time, the TAC level was available, which was 8.1. So from TAC of 0.1 milligram per kilogram per day, it was reduced to 2 milligram, that is 1 milligram twice daily. She received a total ATG of about 100 milligram. with methylprednisolone of 2 grams. And then she was maintained on mycophenolate of 1 gram per day. The creatinine, there was a slow graph function. From 4.2, the creatinine came to 1.8 on POD8 at discharge. The urine output was good. Hemoglobin was stable. Total counts were okay, and she was planned for a discharge. So this was on POD10 when she went back home. She had chills around 4 a.m. at home. No dysuria, loin pain or vomiting. No oliguria from the time of discharge, but only on that day she had urine output of total of 400 ml only when she came to the hospital. So there was a mild pain over the operated side. Drain was only 10 ml, which was serious. Physical examination showed a temperature of 102 Fahrenheit. However, she did not give any history of fever. Only chills were there on that day. BP was 130/70, chest was clear. Abdomen showed a graft tenderness, a graft site mild tenderness, but bowel zones were present. So on evaluation that day, the creatinine was 5.2. At discharge, we noticed that the creatinine was 1.8. And the total count was 21,500 with the neutrophilic leukocytosis. Subsequently, on the same day, evening, the urine output had dropped. The creatinine had gone from 5.2 to 5.6 with the coagulation parameters remaining stable. So she was, cultures were taken, injection meropenem was started, 1 gram IV stat. And in view of suspected probable rejection also, methylprednisolone was also loaded at that time. Ultrasound transplant kidney with Doppler was done. It showed complete absence of intrarenal flow, and main renal artery was not at all visualized. The transplant kidney was 9.5 centimeter. There was raised echo and peripheral hypoechogenicity. There was no perinephric collection. The DJ stent was in situ. It is to be noted that check Doppler done on POD3 and POD7 were normal, showing normal RI. So CT renal angiogram was done. This the CT renal angiogram shows a edematous kidney with perinephric stranding, DJ stent in situ. Here we see that the right internal iliac artery was occluded from the origin itself, where there is a transplant renal artery was anastomosed. This was poor visualization of the renal vein. The transplant kidney was 10.4 centimeter, bulky and diffusely edematous. So this is, she was then immediately taken up for a graft nephrectomy. Here we can see that there is a thrombus being expelled from the anastomotic renal artery. So because of worsening renal function, creatinine being 6.2 on the next day, surgery was done. Possibility of fungal pyelonephritis also was considered. Caspofungin was given. There was intraoperatively, there was foul smell on opening the wound. There was a thrombus in the main renal artery, which was anastomosed to right internal iliac artery. There was a grossly edematous kidney with fluid all around and slough tissue in the perihilar region. It was sent for histopathology, gram stain, fungal stain, culture sensitivity. Causes: acute rejection with the history of fever and chills with neutrophilic leukocytosis. It looked more like an infection, but the thrombosis of renal artery was really not explained. The urine, blood, and tissue culture from the renal biopsy all showed E. coli. So this is the histopathology where we see ghost outlines. We are not able to see nuclei. There was coagulative necrosis. There are certain areas which show even bacterial colonies in the histopathology. There's extensive interstitial edema with interstitial neutrophilic infiltration with features of acute pyelonephritis in the graft kidney. we see a large thrombus in the main renal artery with the clot, and also this is the one in the low power, and this is the same in the high power field. This there is also certain areas where bacterial colonies were visualized within the thrombus also. So it was presumed to be a graft thrombosis. Was it related to E. coli pyelonephritis? We're not very sure, but that is what we have as evidence till now. So this brings us to a discussion of how to manage acute when we suspect acute graft thrombosis. When there is graft site tenderness, severe pain, sudden anuria, and thrombocytopenia, we would like to do an echo color Doppler examination of graft. If there is a renal artery thrombosis, suspicion of renal artery thrombosis, then a CT renal angiogram is to be considered. Transplant renal artery stenosis is about 2 to 7% of early allograft losses in adults, with 35% early allograft loss in children, according to certain studies, with the peak incidence being 48 hours, and 36% of allografts with multiple are seen when there are multiple renal arteries which are being anastomosed. So the predisposing factors are mainly hypovolemia, atherosclerosis, when there is a surgical technique error, when there is a antiphospholipid antibodies, high dose steroids, long cold ischemia time, and there is a delayed graft function, delayed recovery of renal functions. These are predisposing factors. However, the cases identical to ours here, where there is a renal allograft thrombosis in the early post-operative period with an acute pyelonephritis, has not been documented much. And here we see another case from this is a case report which shows there is an early suspicion of renal graft dysfunction when there is a renal allograft thrombosis in the early post-transplant period, when there is a perigraft hematoma on the ultrasound. Here again, the infarcted tubules and glomeruli and some tubules showed bacterial colonies in their case report as well. Their renal artery was thrombosed and macroscopic examination. The graft showed a presence of emphysematous pyelonephritis of the graft kidney. However, in this case report, we do not know there is no documented cultures in this case report. Also, but we have seen infections causing graft thrombosis, but they are generally angioinvasive fungal infections like mucor and aspergillus, and primarily these are donor-derived organisms, and there is or there is a contamination of the preservation fluid, or there is a contamination of the perfusion fluid. So these are two case series. One is from PJ Chandigarh, where there is a mucormycosis of renal allograft. They have documented a lot of cases, about 24 cases of mucormycosis in the transplant kidney. Also, they have case series where donor-derived fungal infections were the cause of pyelonephritis in the recipient. However, the possibilities in our case are E. coli bacteremia causing renal seeding and thrombosis. The source may be contamination during surgery, for which we investigated the perfusion fluid, the operation theater sterility. We cultured everything from as per our infection control protocol, and all were found to be negative in this case. Is it donor derived? We are not very sure. Is it related, underlying infection related to VUR? We're not very sure. Only thing we have is a baseline cultures which are negative in both donor and recipient. So this is a big case series of 214 kidney transplant recipients of acute graft pyelonephritis in early transplant period, where thrombosis is not at all documented as a complication. So we do not really know if this thrombosis can be attributed to the infection itself. But in a native kidney, when there is a renal vein thrombosis, when there is an acute pyelonephritis, there have been documented cases of renal vein thrombosis. mechanisms probably being endothelial surface change and probably endothelitis leading to alteration in the virtue of striatum causing thrombosis. So we have some case series of renal vein thrombosis with urine culture positivity in a native kidney where it can cause where pyelonephritis can result in a renal vein thrombosis. There are also some case reports of native renal artery thrombosis secondary to sepsis and due to pyelonephritis. But most of these cases had an underlying DAC-like picture. Our patient did not have a DAC-like picture at the time of presentation when we did the graft nephrectomy. There are certain mechanisms where which have been described where infection can cause thrombosis. This is a very insightful diagram given in Journal of Circulation, where there are new mechanisms like neutrophil extracellular traps, which are described in formation of thrombosis in the case of infections. So, there are also shows the same article shows how hypoxia, inflammatory signals, pathogen PAMPs and DAMPs can also result in thrombosis of venous thrombosis. But this is all probably in experimental models, but we do not know an actual relationship between infection and thrombosis in our current setting in this patient. So what else could have been done? Probably empiric antibiotics, but that is not the actual answer for why this happened. And if this patient needs a next transplant, should she be worked up for thrombophilia or underlying prothrombotic state is a question. If she is planned for a next, we are planning for a next transplant, but what to be done next is the question. Thank you for giving me the opportunity to present.
Thank you, Dr.
Yeah.
Hello. Thank you, Vivek, Dr. Vivek, for the excellent slides and presentation. And it was a really scary one. And it's very unusual to have a graft artery thrombosis following a pyelonephritis. Actually, one case report, what you have showed is there in that search for this literature. And more common is graft vein thrombosis. Unlikely this patient is having a graft artery thrombosis. Is there any possibility that she is having some hypercoagulable state, underlying hypercoagulable state that has been missed, and infection would have precipitated that thing causing graft artery thrombosis? That might be the one question. Interestingly, it's a very good case. Actually, it's very rare and cannot explain how it happened, whether pyelonephritis has caused thrombosis or thrombosis initially and the pyelonephritis in incident finding, we don't know. But really, it's a very rare case. And I open this for a discussion. Shivakumar sir, your comments on this case and your...
Definitely, because of E. coli relation with a thrombus like this is quite unusual. But
yes, sir.
I have seen with mucor.
Yeah.
Are we pretty sure that there was no mucor at all?
Yes, sir. We got a complete graft nephrectomy specimen.
Okay.
Examine and there is no fungal elements at all. So no.
Okay. Any cultures?
Yes, cultures were done from all blood, urine, and the tissue fluid. Everything grew the same organism with same sensitivity. So there was little doubt. Like that was probably the ultimate reason.
If I am right, patient also received the induction.
Yes, sir. She has got 100 milligrams of ATG, almost 2 grams of steroids, sir. So we had to cut down the CNI as we assumed that press was due to CNI. We had a couple of cases in the last few months, so we reduced the dose by more than half, and we had to give her a little more steroids than usual.
So if you don't mind, it's a live-related transplant, mother being
Yes,
donor.
yes,
so
sir.
Where was the need for ATG?
I think that's a question for all of us. But here in our at an institute, like we generally use ATG for, I would say, almost 80 to 90% of the cases, sir. We do not use much Simulect.
50% HLA match?
Yes, sir. Maybe the dose is little. So we have started with 1 milligram per kilogram and we have moved up to 3 milligram per kilogram induction based on if there is a match or not. If there is no haplo match, we give up to 3 milligram per kilogram. She has got close to 1.5 to 2 milligram per kilogram, sir. That's been our protocol for the last, say, 6-7 years for now.
Okay, so for all the patients, even live related HLA
Yes, sir.
match ATG.
Yes, sir. Only the dose differs between, say, 1 milligram per kilogram to as high as 3 per kilogram.
Okay, so lower intermediate dose.
Yes, sir.
Okay. No, that's one reason where we have to bring in the possibility of making them more susceptible for this sort of infections.
Yes, sir.
And
I agree, sir.
as you said, definitely keeping this incident in view for your coming transplant, you need to have evaluation for the thrombophilic nature.
Yes, sir.
That's one. And it's always better keeping this in view, go for the native kidney nephrectomy, at least the one which has got grade 5.
Okay. Or the VUR, the native kidney, yes, sir.
Because now that there was a blood infection,
Yes.
could also have gone into those native kidneys now.
Okay.
So definitely they become the sources later.
Mm-hmm.
So if you ask me next time, no ATG, and then the native kidney nephrectomy and thrombophilic evaluation.
All right, sir.
These are the things that I would suggest.
So I agree with the other points, but about the ATG, next we are listed on a cadaver and she has been prioritized. So she's going to get a cadaver kidney, but would you again not give ATG for a cadaver kidney as well, sir?
Cadaver is okay, but
Yes.
keeping her in view, if you are planning a transplant within 6 weeks to 12 weeks,
okay,
there is a possibility that the source would be hidden somewhere and maybe quite active. And I do not know how much right I would be. In this sort of situations, I would always like to exclude Bombay blood group.
Okay.
Because 1 or 2 times we burned our fingers.
All right.
The report comes as presence of Bombay blood group when all the events have taken place. So you have to speak to your transfusion people.
All right, sir.
How much of possibility is there for Bombay blood group?
All right, sir.
I think we'll ask Swarna.
So
Yes,
thank you.
madam. Yeah.
Yeah, I would like to initially appreciate Dr. Rajan and Arvind for a wonderful platform, academic platform. I think it's going very great, and this is the 26th episode, I believe. And I'm also honored to co-chair with Dr. Shivkumar sir because he's my first teacher in nephrology. Before joining DM at NIMS, I joined. I worked under sir, and he has inspired me to take nephrology. I think I would like to really thank in this platform for motivating me to take nephrology. Now, coming to the present case, I really appreciate Vivek for such a, bringing in such a interesting case for discussion. And Dr. Venkatesh, you have been, treated this patient very well. But what I think is like in present times with availability of all the tools to better the pre-transplant workup and better the match, haplo match and the good surgical techniques, the thrombosis is a very rare complication, and if at all it happens, we should think of particularly the rejection. And the most common patients with deceased donor, but I believe it's a live donor now here.
Yes.
And the other thing I would like to point is like it's a child, 25 years, I don't know. One of the complication in pediatric
T is 25.
Disparity in the vessels. And I believe there was an accessory renal artery here, and which was anastomosed to both and external and internal. So this is probably a disparity, one of the precipitating event. And the patient being a female child, I don't know about the prothrombotic state as Kumar sir has suggested. You should also look for the APLA and then the thrombotics. Whether it's, I'm still confused whether it's a thrombosis, which is the initial event, which has, led to because even in the biopsy, you are sure there's a ghost, there's a necrotic and then probably a secondary infection. So, and if you think infection being the first event and E. coli causing thrombosis has been rarely been, documented. And we see thrombosis with the infection with particularly fungus, as has been highlighted by the presenter. That we see in fungal infection, angioinvasive, the aspergillosis or mucormycosis. We had one such case within 1 week. Patient was a live related patient, had a sudden fall in the urine output. We wanted to do a biopsy. We shifted the patient for the graft biopsy to ultrasound room. Those days we didn't have this ultrasound available with us. So we shifted the patient, and to our surprise, when we tried to do a biopsy, we saw that thrombus, and during the biopsy, it's a procedure itself, patient went into the rupture, and then patient was wheeled into the theater immediately from the ultrasound room, and we were surprised to see there was a big thrombus. It got ruptured, and then subsequently the post the nephrectomy specimen showed a fungal the mucormycosis. So it happens mostly with fungal invasive rather than the bacterial. So here, if we think it's a bacterial infection causing thrombosis, as Shivakumar sir has suggested, the risk factor being the VUR. VUR and female is also one of the risk factor more for infection. So that could be one of the possibility, I suggest. And I was a little surprised, during the second, when the presentation itself was fever and leukocytosis where the graft tenderness was there. And she was given IV methylprednisolone, when she presented. And did you look for the Doppler before you went on to CT angio? Doppler, did it pick up the graft perfusion? Missed that slide. So otherwise, I think it's well managed, and I think that's what we could have done. And you are planning for the second transplant, of course, we should go for a deceased donor only. So again, the rejection should be looked into, because second transplant again is a highly sensitized patient, and more chances of rejection would be there. That will again precipitate thrombus. And this being a case of VUR, so you should look at as suggested, nephrectomy, and the urinary infection before you go for transplantation, and of course optimization of the immunosuppression. So these are my points.
Thank you, ma'am.
Yeah, Rajan, let me respond, Dr. Rajan.
Yeah, nothing.
So the Doppler was done before that itself showed no flow, ma'am. So we just had to confirm with the CT angio. As far as the methylprednisolone, I can't tell anything but to agree with you. Maybe we should not have given that.
Dr. Venkatesh, one question is, before pre-transplant, is the recipient is completely sterile actually, because she's a known VUR?
The VUR was diagnosed only maybe a couple of weeks before the transplant as a part of routine evaluation. That also we did not do it, as there was no history of recurrent UTI or anything. It was done at her native, and it turned out to be VUR, but a baseline culture was sterile for both the donor as well as the recipient.
So when you do the cultures before transplant, actually for the recipient?
Actually, we do not do it, Dr. Rajan, both for the donor and recipient. In this case, we are done only because of this documented VUR.
Okay, it was sterile only, no?
Yes, it was sterile, done maybe within a week of transplant, I can say.
So it's very unusual to have a E. coli pyelonephritis causing renal artery thrombosis. So if you're planning for a second transplant, you should be very careful enough to rule out hypercoagulable state in this patient. She was on fistula, no? She was having a working fistula.
No, she was dialyzed only some 3 or 4 times with a temporary line, Dr. Rajan.
So, but what I feel is she need to have some hypercoagulation state workup actually, definitely before going for second transplant, because it cannot be explained by E. coli pyelonephritis causing thrombosis, graft artery thrombosis. It's very much unusual. There is only one case report, as you have shown before.
Yes.
And tacrolimus level, what was the level at the time of actually?
The only level was done on third day. We did not do it on the third day, but she had a fit, and we assumed it was pressed due to CNI, and we did the level. It was 8.3, and it was reduced from 6 milligrams to, I think it is 3 milligram or something.
So how common you are seeing press from tacrolimus actually? One of the chat questions was also there.
Yeah, so I would probably attribute it to the hypertension if it was there, but her BP was more or less okay at that time. So if the BP is high, probably I would have thought that as the reason for this this syndrome, but it was not there, and naturally, I'm not sure, please correct me if I'm wrong. I think this should be the second common reason after that, and this is the third or fourth patient in the last a year and a half, third patient at least. And all of them, we did not have to stop the CNI. We have to only reduce the dose, and it did not recur again.
Can I know about the marital status and pregnancy complications she had before?
See, the main issue, I mean, it all started with an anxious to conceive and female. So that is when she was evaluated, and she was found to be having high creatinine.
Infertility was one of the presentation.
Yes, ma'am.
And after post-COVID, I think one should go into the different diagnosis or this thrombotic status COVID infection or the vaccination. So
Yes,
did you look into the the infection? Did she had a recent infection, or even vaccination also? Vaccination booster also can precipitate.
As far as the infection goes, still we continue doing it for the donor and recipient. Again, I'm not sure if that is right or wrong. Immediately before the surgery, 3 or 4 days before the surgery, as a routine for all, and it was documented to be negative. At the vaccination, Vivek, any idea? I'm not really sure when was she vaccinated.
She has received both. She has received 2 doses plus 1 booster, sir.
All right.
So, Dr. Vel Arvind, you have some questions on chat. Do you want to share some questions or insights into that?
Yeah, it's a good presentation, but anyhow, sad for the patient. And this Raj told me, I mean, Venki told me a few days, a month ago about this case, which is not a detail about, but I was thinking since then what could have been. But after the presentation, I had one patient, right, similar patient, but I tell you, when you have an isolated vascular event, like, renal graft artery thrombosis, this will not behave like, leukocytosis, graft artery thrombosis will go very silent. Patient will come with even some native kidney output is good. They'll come with normal output. You do ultrasound, just instantly you find there'll be no flow. So certainly this case is preceded with the infection, then it has gone for the thrombosis, because the putrefaction process, all the foul smelling discharge, everything, I think indicates some event could have happened, because she was discharged on the 8th day and 3 days she was at home, and probably that is the area where she had some problem. Probably even immune suppression related or whatever it is. But I tell you, the point is, I gave a point in chat box also. Whenever you discharge a patient, I think in the last day you have to document and send. This is my personal experience, and just make a point. And there is no collection, bladder is empty. I mean, there's I think he has presented drain also, where he was it removed on the 8th, or because the drain he said about serious discharge and some 20 ml he said. Was she sent with the drain in situ?
Yes,
I don't
sir.
know.
She was sent with the drains.
Okay. So there are a lot of issues, but this case, I think if you think, deal clearly of internal iliac artery thrombosis, the patient will never present with fever or anything. It will go very silent. I had a similar patient that 5 years ago. Patient came in the follow-up and the creatinine was raised and patient was absolutely all right. When I did an ultrasound, there is no flow. So it go, and rather than going of swollen kidney, the patients with the internal artery stenosis, the graft will be like some normal size. There will be no swelling, no graft sinus. So I think this is preceded by infection, which has gone for some kind of late complication. That's what we can presume. And we have to look for the causes, and we have to take cue from this case and put into clinical practice and ongoing clinical. Similar kind of situation should not arise anymore.
Good point. Actually, the patient is planned for a second transplant. As Shivakumar sir told, the patient is having a view or bilateral native nephrectomy is indicated, or any other procedure can you advocate, sir? Is there any other thing can be done? Or like if the patient doesn't have urine output, you can tie in the ureter, distal ureter. Will suffix or nephrectomy has to be done for this patient if she is going for a second transplant?
You're asking me?
Hey, open for sir.
No, that's what. If I were to be the treating physician, I would definitely go for it, for the simple reason they are the vulnerable areas to keep these first points inside.
Okay, sir.
So it's, God forbid,
okay.
If a similar nature occurs in the second transplant, then
okay.
we feel awfully bad. So
okay.
that's the reason, to be more protective, I would say.
Fine.
Of both the kidneys, sir. She's got a grade 3 in one, and
because for E. coli to get large, how much of tissue is needed? Both are dead for all practical purposes, and both do contain some urine. Very unhealthy. So it's better to go totally nephrectomy with ureterectomy. Not even a trace to remain.
I agree with sir's point. That's a good point. Nephrectomy nephrectomy, the uretrectomy, not ligation of both ureter. That should never be done, because the abdomen will have like a cricket ball, like a football inside. Because slowly the native will go into it. I think if you want to go for it, go for a native and ureteronephrectomy. That's the way you should go for it.
Okay. I think we are getting ahead of, we're getting late in time. Actually, if there are no further questions, and I think we have answered our questions on chat boxes, actually, we can move to the second case. Actually, we are running late of time. So thank you very much, Dr. Venkatesh Rajkumar and Dr. Vivek Ashok for bringing in such a wonderful and rare case to this forum. And I invite Dr. Balaji Krishnan to share his screen and start his presentation.
Yeah. I'd sent my presentation. Is it okay? I can also share it. No problem. Is it seen now?
Yeah. Go ahead.
Yeah. Good evening, Dr. Shivkumar, Dr. Swarnalata. I remember Dr. Shivkumar during my PG days. I don't remember which exam or which presentation it was. Sir had told me to slow down. And I still remember that. Not only sir's teachings in nephrology are very famous, but he also shaped a student very well, which I even now remember. Am I audible?
Yes,
Yeah, go ahead.
Yeah, sorry. So, so good evening, Dr. Swarnalata. Thanks, Dr. Rajan and Vel Arvind for this opportunity. So, I'll be presenting a successful treatment of cutaneous mucormycosis after renal transplantation. So, this was Mr. C, who was a type 2, who was a diabetic from the last 15 years, who was on insulin, hypertension from the last 5 years. He has chronic kidney disease stage 5 due to diabetic nephropathy. He was on hemodialysis for 3 years through a fistula. He had a ischemic stroke, left hemiparesis, and he recovered fully. He had no residual deficits. He also had chronic non-valvular atrial fibrillation, for which he was on rate controlling drugs. And also he was on anticoagulants. He was vaccinated with 2 doses of Covishield, and there was no COVID infection before the deceased donor transplant, which happened on 17th October 2021. So the donor details, he was a 33-year-old donor after brain death, and he had RTA with subarachnoid hemorrhage. Septic workup for the donor was negative. The cultures which were sent prior to harvest was followed and it was negative. There was extensive oral candida in the donor on examination. When we saw him in the ICU. The donor had normal creatinine with a good urine output at the time of organ harvesting. The CTC cross-match was negative. We also did a COVID as a part of the routine protocol, and RT-PCR COVID was negative. Our institute received the left kidney for transplant with a single artery and vein. At that time, anti-thymocyte globulin was not available. So only the anti-lymphocyte globulin was available. And we had to give 3 mg per kg. Standard dose is somewhere between 3 to 5 mg per kg. So we used 3 mg per kg as the induction agent on day 0. And we subsequently repeated it on day 3. The total ischemia time was 2 hours and 10 minutes. At the time of surgery, there was a DJ stent which was placed. Immediate urine output was seen after the clamp release in anastomosis. We did give injection methylprednisolone 500 mg IV at the clamp release and continued it for 3 days. Standard triple immunosuppression with 3 drugs post-op was given. His TAC level was 6 on post-op day 4. So we increased the dose by 1 milligram. The ultrasound transplant kidney with a Doppler showed an RI of 0.7. As it was a cadaveric donor, we have a protocol that we keep them on empirical antibiotics and antifungal. He was on IV fluconazole 400 mg IV stat and 200 mg IV OD, and also cefoperazone sulbactam 1.5 grams IV twice a day. For this patient, we also had another rationale for initiating on fluconazole because on examination, the donor had extensive oral candidiasis. Although it was not proven, but by any scraping or histological examination. The donor cultures which were followed, as I mentioned, were negative. So the patient's creatinine was 0.8 on day 9, and he was discharged from the hospital on day 9. He had very high, he had uncontrolled diabetes, erratic sugars had to get controlled. He was on long-acting, that is a basal insulin, Lantus, and also on, and also short and long-acting insulin. The post-operative course was slightly prolonged because he had initial ileus. So he was discharged with standard triple immunosuppression with oral valganciclovir and cotrimoxazole prophylaxis. He was on regular alternate day follow-up. On post-operative day 13, he presented with discharge from the wound site. The wound swab for culture and gram stain were taken, and he was started on amoxicillin augmented, that is amoxiclav 625 mg twice a day. 5 days later, when he presented, there was mild spreading of the with black discoloration with adjacent areas, with a few areas of early necrosis seen. Our surgeons did an alternate clip removal. The initial wound culture and gram stain were negative. We did repeat the wound swab for gram stain, culture, and fungal stain. And the fungal stain grew mucor species was grown in the culture. This was the lactophenol cotton mount blue, which showed typical features of mucor or rhizopus species. And the culture also demonstrating on the right side early black colonies, which was confluent later. So the clinical course, this patient was started with IV liposomal amphotericin B, 3 mg per kg IV, 3 mg per kg IV once a day. And he had to undergo extensive wound debridement. And he underwent around 3 times in 2 weeks, and they had to clean up the wound to remove all the slough and see the viable area. As the patient was on IV liposomal amphotericin B, here we had to monitor the electrolytes. We did develop we did see hypomagnesemia and also hypokalemia with mild azotemia. Although the incidence is supposed to be less in liposomal amphotericin, we did notice these, and this was corrected. The patient throughout this course had normal graft function. We did correct the dehydration, and we were continuously monitoring the TAC levels, and that was maintained, and it was thank God the graft function was normal, and MMF was stopped once we knew there was a fatal once we knew that the bug itself was mucor. We stopped MMF and we continued low dose steroids with TAC. Somehow he had some diarrhea because of probably antibiotic induced, and there was high TAC levels, and it was finally reduced to 1 milligrams twice daily. This was the wound which was taken later during the course when he had come for follow-up, and later when he was admitted. You could see that the wound is kind of excavating inside, and it's spread everywhere. It's gaping, it's wide. You could see areas of wound slough which are there. The healthy pink granulation tissue was never to be seen. It was too deep. So we had to go on doing the wound debridement till we finally saw some pink granulation tissue. How deep did it go? That was the scare. I mean, whether it would just go inside and whether it would evade our graft kidney and cause graft mucormycosis was our concern. And the CT scan showed the graft kidney. You could see the picture on the top left-hand side where the kidney is just as close to the surface or the skin. There's hardly any tissue left or any space left. And this was a nightmare what the plastic surgeons faced. And he had to undergo daily dressings, and the wound was exposed. As I mentioned, the graft kidney was only one layer fascia beneath. And thank God there was no involvement of the graft. There was no graft dysfunction or decrease in the urine output. And we never had to do a graft, think of, at least a non-functioning graft at this stage. So the patient did receive 14 days of liposomal amphotericin B. And then we followed it up with isavuconazole for 3 months. This isavuconazole, the dose is 200 mg per oral 3 times a day. for 6 doses, followed by once a day for 3 months. And this was the dose recommended by our infectious disease specialist because of the extensive wound necrosis caused by the myocard. Finally, after 1.5 months of treatment, he underwent a split skin grafting from his left thigh, and this picture was taken. The surgery was done 1.5 months later after the discharge of the wound treatment. That is, after he was discharged and he was on oral isavuconazole. 1.5 months later, this split skin graft was done. And this was the uptake, which was seen after, I think, 3 months after the date of transplant surgery. So this was the case presentation. What we had was quite prolonged, and it was a nightmare to preserve the kidney. And currently, after all this, but he is doing well. He's currently on triple immunosuppression. We did restart mycophenolate, and further we went up to 250 milligrams twice a day, and he's on that dose with the standard dose of low dose steroids with tacrolimus. So there was good uptake of the skin graft over the graft site, as in this case. A brief clinical discussion. As we know that mucormycosis is mucor is ubiquitous saprophyte. It's spread via airborne, and the main route of infection is respiratory tract, and hence the prominent cause is the rhinocerebral mucormycosis. So among all solid organ transplant recipients, the mucor incidence is variable, reported from 0.4 to 16%. This is reported from the TransNet, that is the Transplant Associated Infection Surveillance Network study. In renal transplant recipients, we have an incidence ranging from 0.5 to 1.5%. Of course, the rhino-oculocerebral mucor is the most common. So what are the risk factors of mucor in the TransNet study? As we all know, the diabetes mellitus and uncontrolled diabetes mellitus, and this patient did have that. Use of T-cell depleting agents. Yes, this patient also had use of T-cell depleting agent, mainly anti-lymphocyte globulin. Presence of neutropenia, a graft rejection, a use of ureteral stents. I did forgot to mention that the stent was removed as per our routine protocol at the end of 4 weeks after the date of transplant. Prior exposure to voriconazole or capsofungin was also a risk factor. Prolonged ICU stay, and the use of tacrolimus. Now, tacrolimus, according to few studies, has some in vitro activity against these fungal species. Even when I was preparing for this, I came to know that tacrolimus has some in vitro antifungal activity against mucor, and this is not considered a risk factor. So there are reports of donor transmission of mucor through the allografts, and this case, in this case, it occurs very early after transplant, and this has been reported in the AJT. So now there is a growing trend of mucor in renal transplant patients, especially after the COVID pandemic. I should tell that estimated prevalence is around 70 times higher than the global data. And after the rhinocerebral ocular mucor, cutaneous mucor is the second most common form of mucormycosis. Now, this is a study published. This is a study from India, and this has been published, and it shows that of late in the years to come, there's a slight increase in the incidence of the cutaneous mucor in renal transplant or solid organ transplant recipients. It is very rare. Cutaneous mucor is only seen in 10 to 20% of all the cases. The direct spread, that is direct inoculation of the fungus through the burns, trauma, insulin injection sites, or nebulizers. Indirect spread, that is from hematogenous spread, is also reported to be one of the causes. So outbreaks of mucor in healthcare centers due to contaminated adhesive tape, wooden tongue depressors, osteotomy bags, and building construction happening near the hospital were found to be few risk factors for cutaneous mucormycosis. It has a very gradual onset. They have a lot of indurated plaques that are erythematous to purple in color, and they become necrotic and erythematous halo, and they have an HR-like picture. This is how cutaneous mucor has been classically described in the literature. Other lesions like targetoid lesions, tender nodules, and ulcers have also been described. In liver transplant recipients, they have reported mucor as a non-healing sinus and a fistula from the skin to the liver. The overall mortality in cutaneous mucor is definitely less, and it's quite obvious than the other mucor. In different case series, it ranged from 25 to 31%. In localized cutaneous mucormycosis, the mortality ranged from 4 to 10%. And if you have mucor, which is invading deep, and of course, because of this fungus is angioinvasive, it can spread through the blood vessels. The mortality is more if the mucor goes more deep into the skin. And that's quite obvious with the clinical presentation. Isavuconazole, this drug, now we all are quite familiar with posaconazole and how it has to be used in our renal transplant recipients. How this posaconazole is quite notorious to have drug interactions causing increasing tacrolimus levels. How it has a variable pharmacokinetic profile with erratic absorption. It is supposed to have it after a fatty meal, and there are so many restrictions with posaconazole. To counteract all that, this drug was into the trials, phase 2 and phase 3 trials in 2010. And by 2016, the drug came into clinical use, and there have been reports of these drugs which has been used for invasive aspergillosis and also mucormycosis. And I'll be telling a few more slides about this new drug, which has been less reported in renal transplant recipients. It enjoys a spotlight in invasive fungal infections, that is aspergillosis and mucor. It is supposed to be more potent than posaconazole. It has a better pharmacokinetic potential. It's better absorbed when compared to posa, less interaction with CNIs. When we use this for our patient, we did monitor the tacrolimus level in between, and the levels were not very erratic. It did not fluctuate here. Before initiating isavuconazole, the TAC level was around 8 or 9. It just went maximum up to 10 or 11. And then we never had to remove tacrolimus completely from our patient, and it's better absorbed. It's better safety profile, less hepatotoxic as compared to posaconazole, and has a better GI tolerability also. This is the brand name which is available. It's called Cresemba, and 100 milligrams tablet. The posaconazole is available only in the oral formulation. The isavuconazole is available in oral as well as IV. And we should know that. And the cost is something which will choke all of us, and somehow this patient had some insurance and we don't know, and some of the cost is around 41,700 for 7 capsules. So one capsule is around 5,200. So that's the cost. So the dose is 200 milligrams of isavuconazole every 8th hourly, or oral for 6 doses. Then we followed by once a day for 14 days. It comes in 372 milligrams IV preparation and 186 milligrams oral preparation. Both have the elemental drug of 200 mg. So there have been studies to demonstrate the safety and the efficacy of this drug, isavuconazole, in the treatment of fungal infections in solid organ transplant recipients, the ISASOT study. And for the frequency of the immunosuppressive treatment and dose changes after the introduction and discontinuation of isavuconazole has been discussed in this study, and they found it reliably safe to be used in all solid organ transplant recipients. Now, this case report, which was published in the year 2019, there was a case of gastric mucormycosis in a renal transplant patient. And this patient was treated with isavuconazole monotherapy. Also, quite surprising that it was reported as a successful treatment, although it was a invasive mucor in a soft tissue in an organ. They did use isavuconazole monotherapy as a parenteral form, and then they treated it. We have other trials. Probably these are all pharmac-driven trials, but we need more solid data. The SECURE trial, it dealt with isavuconazole and primary aspergillosis, and it was associated with fewer drug-related treatment, emergent adverse events than voriconazole. The VITAL study, this involved 37 patients from 34 centers worldwide. Adult patients with invasive mucor were enrolled. Cases were matched with amphotericin B. It was non-inferior and comparable outcomes. There were less side effects reported by this study. The funding of this study was from the Astellas Pharma, which was clearly mentioned in the study. And of course, as I said, we need more evidence on this isavuconazole before it's widely recommended. And of course, the economics of this drug has to be a little better reasonable to be available to all. So finally, this patient is now doing well. The whole nightmare and challenge for us was to beat the cutaneous mucor aggressively and at an early stage and prevent it from evading the muscles and the graft, and which was challenging. And despite all this, now he is fine and he's doing well. And I would also like to bring to notice that this new drug isavuconazole, when we used it in our patient, did not have much interaction with tacrolimus. As I mentioned, the levels were quite safe, and this drug can be used if cost is not a concern. Thank you.
Thank you, Dr. Balaji Krishnan, for a wonderful presentation. I must congratulate you that you have pulled out the patient from mucormycosis. Probably, I think it is a less virulent form of mucormycosis. Some species like irregularis, like it will have a very indolent course. Some mucor will exist for more than 10 to 15 years also. There are case reports also that. So in your case, what could be the factor? What could be the reason for cutaneous mucor? Could you find any factor that would have been there?
The only thing what we in our hospital, me and my surgeon, were all pondering was that there was some kind of a construction activity going in the hospital. Maybe it's a little outside the operation theater, I know all that, but maybe there have been spores of fungi are known to liberate when some construction activity is going on. And that was the only reason. And probably this case was also in the middle of in between the second and the third wave of the COVID pandemic. And probably I would attribute it to probably the construction, the work which is going on in the hospital. And we had a detailed discussion about it. And even there were one more liver transplant recipient in our hospital at the same time had aspergillus of the wound, and probably not around the same time. I should say around 4 months later. So probably we don't know whether that could be a contributing factor.
An interesting point in your slide that one of the important reason for mucor entry is adhesive tapes, actually, that plasters and dressings. Change of dressing, unsterile way of change of dressing might be the reason also. That is one of the important causes of cutaneous mucor. Anyway, you have managed the patient well. And one point to consider, one point to ask is, how do you manage your tacrolimus and isavuconazole? Though the interaction is less, so how do you see the TAC levels going up with isavuconazole?
Yeah, because this is our first my first experience using this drug isavuconazole, and when we had started it, we had a baseline TAC level. And after initiating this isavuconazole, 2 days later, we repeated the TAC level, and that did not rise much. The rise of around 4 nanograms was seen after a week. And after that, it remained at that level, and there was no change in the azotemia, so we didn't bother to reduce the TAC further. So, and then from then on, we went on monitoring it every week. And then it was continued, and the levels did not fluctuate. We just stopped monitoring, and we just based on the creatinine.
What made you the end point of 3 months of isavuconazole? Did you do the biopsy of the lesion to confirm the absence of mucor?
No, what was the data to the use of isavuconazole for 3 months was from the VITAL study, what was published, and they recommend for cutaneous mucor to give an extend the treatment for 3 months if there is involvement of deeper subcutaneous tissues. And although we need more recommendations on that, how to use this drug for the cutaneous mucor, and the 3 months duration was from the study. Regarding the eradication of mucor, we did not repeat the fungal culture, and it was just the plastic surgeon who said that the wound is healthy, and he was quite sure that the margins were clear, and he just went ahead with SSG. We did not repeat the fungal culture from the wound.
I think if I remember that that should be histopathology is a confirmatory of mucor, and the edge of the lesion should be biopsy to look for the invasiveness of the mucor and also presence of mucor to judge for the treatment.
Yes.
So.
Yeah. So the histopathology, I don't think we did for this case. So let me just go back. Let me just go back and get that. Sure.
Dr. Shivakumar sir, your comments and your inputs, sir.
So I'm interested to know what has happened to the other graft where it was put into somebody else.
The other graft was taken to, yeah, I think it was in Stanley, sir. The patient is doing well. They did not have any fungal infection.
Okay, so
We followed up, sir. We followed it up. We followed it up.
okay, so because we had a suspicion whether the oral cavity candida could have been the source. So still there is a possibility, but probably the strength as an evidence has come down because the other fellow is looking okay.
Yes, sir.
One. Second thing is the same question which I have asked the earlier speaker. A diabetic elderly man who is already immunocompromised. So instead of probably ALG, IL-2 blocker would have been more docile in a situation like this. That's one. The second thing is, as Rajarajan has suggested, is any lymph nodal biopsy was seen the draining area? Because if you see the secure trial, it is around 40-45 weeks plus minus standard deviation. So that was the duration that they have given the drug, and your patient is only 16 weeks. How much you said?
Yes, sir. 16. He had the infection at yes.
So he is at the borderline now. So we should be cautious periodically doing an ultrasound, know whether there is any collection around. That's one aspect. And the other thing that I'm surprised is when he came to you on 13th day with a little bit of pus at the incision site, was KOH mount was not done immediately, was ultrasound done was not immediately, because there was a gap of about 6 days by the time we really saw the necrosis.
Yes, sir. Yeah, yeah.
So invariably we do KOH at least to make sure that the fungus is not there.
Okay, sir. We didn't do it initially, actually.
It's a routine and it's very easy to do with microbiology. It's not a culture. It's just a
okay, sir. Okay.
And then an ultrasound always, because whenever we see the pus, we do not know the source at what depth it is. And ultrasound probably would always help as an immediate investigation. But I should really congratulate, and then God has been on your side. Otherwise, to get rid of a fungal infection and get the gap filled. See, we had a patient where it took more than 6 months to fill the gap after the graft nephrectomy. Because every day it was a pathetic sight to look at the situation. So it's a very difficult situation, I would say. Congrats.
Thank you, sir. Thank you. Thank you for your inputs.
Swarnalata madam, your comments.
Yeah, I think I should appreciate Dr. Balaji for treating such patient. It was so scary to look at the wound, and knowing that it is a mucormycosis, I can imagine how many sleep at nights you had. And I also understand why it's called now peculiar, because if you are not given the microbiological reports, we will assume first to be the angioinvasive mucormycosis, second to be the E. coli. So it's like a reverse now. So coming to the case like the wound infections, so we are seeing a lot of cases, particularly the deceased donor, when the donor is not prepared properly. And the recipient factors being the obesity, diabetes, female patients, we see a lot of wound infections, and most of them being the bacterial. And we did come across 2 patients. One was an atypical mycobacterium, so that was I believe it was a contamination. Then we had 2 such cases, and then it was non-healing ulcers. Then when we had to do a repeated biopsies, and we had talked to our microbiologist to look for the other organisms. There we found out to be a mycobacterium, atypical mycobacteria. And coming to the cutaneous, the mucormycosis, I think I have presented that case in this forum. We had very bad case of deceased donor presenting with a cutaneous mucormycosis of the lower limb. It was extensive necrosis of the leg and in the thigh, exposing the shin bones. So it was to that extent, and it was difficult to diagnose initially, because initially it was negative. Microbiological report was negative, but with a deeper and what you call edge biopsies, we could make out it to be a fungal infection, a mucormycosis. And it was very difficult for us to treat that patient, because that was during the peak COVID time. The second way, where the black fungus was very common and there was scarcity of availability of amphotericin, liposomal amphotericin B as well. So we had to have a combination of everything. Amphotericin was exhausted. Then we, we used posaconazole. In fact, I remember we used the suspensions of posaconazole because the tablet was not available. And isavuconazole also we had to have a mix and match. And it was so extensive, we were afraid whether we lose a patient. So, successfully we could, treat the patient, and it took almost a year. We were continuing the antifungals almost a year, and it was a lot of defect was there, skin defect was there, and we were trying to contact with the even plastic surgeon. But fortunately, everything, the patient did not require any the graft. The whole, the wound got contracted, and
okay. Oh wow. Okay. Okay.
Yes. And he's doing well now with normal graft function. He's doing well now. I think I have presented this in forum. If people remember, that was a challenge for us, and getting the drug also was very challenging for us. We should really appreciate for successfully managing. I think, as I said, luck was also in your favor.
Definitely, I should say that. Yeah.
So, chat says that the voriconazole initial. What was the TAC level when you started on voriconazole? I think it was around 4 you have mentioned.
Yeah, 6 I think, and we have a protocol of repeating at day 4 and at day 10. That was 6 and 8. It did not budge.
Even with voriconazole, right?
So, with the initial was fluconazole.
Fluconazole, even with fluconazole.
It didn't go up. Yeah, it didn't go up.
And I
if there are no
donor derived, because donor derived, it should be a systemic. It's not cutaneous.
Yes, ma'am. Yes,
cutaneous. Fungal infection or the cutaneous. And as I said, mostly it could be contamination, OT contamination, or
yeah, definitely.
Mostly like this dressing will be changed by the sisters in OP. I think so, probably.
Yeah.
That surgical site infection site. So probably that might be the reason for the entry of cutaneous mucus. So if there are no further questions, any other question, madam?
Yeah, just
your comments.
Because when talking about the contamination, so as I said, we had 2 successive cases of atypical mycobacterium. So I've looked into the cause, and it was found the suture material was the culprit.
Okay.
Should also look at the batch and the suture material.
Fine there. Okay, understood.
Which one, ma'am? Which suture material is it? It's internally used.
I really remember now because it was long back, and because I could just remember because the discussion has come now regarding the contamination.
Yes, thanks, ma'am. Thank you. Anyway, it's a good point.
Thank you, madam. If there are no further questions, it was wonderful sessions. I must first thanks and congratulate both the speakers for their wonderful presentation. And they have taken much time in preparing the slides, and hands up to them for the good presentation. I must thank profoundly Dr. Shivakumar sir, who came along with the PGs. That's why he's called as a Dronacharya by. So real teacher evident from the screen actually. So thank you for spending your valuable time with us, sir. Swarnalatha madam, as always, you are always helpful to us, and your knowledge sharing is always it always mean a lot for us. And thank you participants for their active discussions, and thank you MQ team for providing this technical support. And our next session will be on June 1st, Saturday, and the formal invitation will be following in a couple of weeks. Thank you very much for attending this forum. Have a wonderful weekend.
We would love to join.
Thank you, sir.
And keep going.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am.
Thanks.
Bye.
Thank you, sir. Thank you. Thank you.
Good night, Raj. Good night, everyone.
Good night. Good night.
Sir, thank you, sir. Good night, sir.